next session will be a sponsor session by Edwards, and basically it's a focus on second valve strategies with the SAPIEN Ultra RESILIA. So we decided to split up this kind of session. Basically it's going to be case-based. We'll start with transcatheter mitral valve, and then we have two very, very interesting valve aortics. And so we'll present the mitral case, have a discussion, then present the two aortic cases, and carry out a discussion at this point. So without further ado, I'd introduce Dr. Mohammed Al-Hijji to present a transcatheter mitral valve case.
Okay, thank you. So these are my disclosures. So we'll jump into the case. Our case is a very young patient, actually, 28-year-old, very cachectic woman who presented to us with 1-year history of recurrent hospitalization for heart failure with NYHA class 3. So she had a mitral valve replacement with a tissue valve when she was younger, probably 19 years old, with a MitraFlow 29, done for a rheumatic mitral valve. That we know that true ID for MitraFlow is 24.5. And right away after surgery, actually, she had TIA stroke. And since then, she's been on Coumadin, although she's not taking it very frequently. And she has subtherapeutic INR most of the time. So the workup showed prostatic mitral valve stenosis and mild to moderate rheumatic aortic regurgitation, and that's her medications. So she actually was referred to us in the structural heart disease clinic by a surgeon. The idea here is to limit the number of sternotomies in her lifetime, because the patient is adamant to go either with a tissue valve, and as she would not be compliant with warfarin therapy if she have a mechanical valve. So I guess we can stop here. Mahmoud, the panel, what do you think of this strategy?
Ahmed, what do you think?
Well, the patient is young. That's the striking point of this whole presentation. And maybe the lifetime management of such a patient with a surgical intervention. So let's delay the last surgery as way as possible by doing any other method. And looking at the valve and the size of the valve, we can get a decent size into this mitral flow. So maybe I would agree on the decision, or the collective decision of the percutaneous option.
Yeah, so that was the thought process, especially that she has also aortic valve disease that might progress over time, and she will need a double valve in the future. This is not a common, actually, pathway in adult congenital patients where they get multiple transcatheter therapies to limit the number of sternotomies. So that's here actually workup. That's the transesophageal echo. You can see that the valve is very fixed, actually. It's not opening, very degenerated, with a mean gradient of 18 millimeter mercury across the valve. Very high gradient. So we did the CT analysis. All patients for mitral valve interventions need to have a CT analysis. We confirmed that the actual valve was MitraFlow 29 because we are getting closer diameters to the true ID, 24.5. And as in most valve-in-valve cases, the new LVOT is not an issue, and the risk of obstruction is low, or LVOT obstruction. Then we also looked at the septum and the transseptal strategy. As you can see that the heart is astonishingly rotated. The other thing is that you can see that the RA size is, the RA is really squished by the LA, and you can see that the IVC in the lower panel is in a different kind of zip code compared to the SVC. And that's because of the amount of pressure on the RA. So we anticipated a very difficult transseptal. And in addition to that, you can see that the orientation of the LV is very vertical rather than horizontal. So those are the procedural plan or strategy. So you're planning to do it under TE guidance, general anesthesia. Usually for those cases, you want to achieve posterior inferior puncture that will improve your coaxiality and delivery of the valve across the mitral valve. In all of those cases, I use Sentinel cerebral protection device. I don't have data to support it, but we do that. We cross the valve using steerable sheath and actually mother and child guide and a pigtail to help delivering the stiff wire across the mitral valve. Sometimes that's an issue. We're planning to use Safari. In those cases, because the left atria is a posterior structure, the E logo of the delivery sheath should be down, so you can flex toward the mitral valve. We are planning to dilate pace if needed using the wire. Also, we know about the MitraFlow that it's a fracturable valve using non-compliant balloons. But the largest size non-compliant balloon that we have in our shelf is 26 Atlas. So we'll try to modify and expand as much the valve that we'll use. And we are planning to use a 26 SAPIEN 3 with 3 Ultra with 2 additional cc of contrast. So we usually don't close our ASDs unless it's leading to significant right to left shunt. And for venous accesses, we close it using figure-of-8 stitch rather than ProGlide. So as you can see, we anticipated this. You can see that the RA is very squished in the, as shown here in the echo image. Significant contrast in the LA. The SVC is almost obliterated by the pressure. So we had difficulty to navigate from the femoral vein into the SVC, so we had to use multi-purpose to get into the SVC. And we left actually a wire there just as a marker for us to, if we fail with our first transeptal puncture, to be able to get to the SVC again. And of course, we failed. You can see this is the neutral position of the transeptal puncture. It's very anterior toward the valve. You don't want to puncture here. And as we slide down, we weren't able to go posteriorly. So we attempt twice using the transeptal sheath, and then we switch to steerable sheath. Here we use the Gillis sheath. With the steerable maneuvers and torque, we were able to achieve a good location at the septum. You can see here, we are almost, I'm not sure. We are almost mid in terms of superior inferior position, and we are very inferior, very posterior in the anterior posterior axis. And that's what we have on X-ray. I think X-ray helps a lot to know your trajectory across the aortic valve. So we couldn't use a needle here because whenever we introduce the needle, you lose the angulation of the steerable guide. So we use a stator wire. The other wire that you can use is a SafeSeft wire, which actually can cross the septum, and then it will form a kind of a J-tip that will can be used safely to cross the septum. But we don't have that on our shelf, so we used an electrified stator wire. We carefully advanced the stator wire to the pulmonic vein, and we used balloon-assisted tracking technique to deliver the steerable sheath. And afterward, we crossed the valve using the mother and child with a pigtail and a multi-purpose guide to give us more support. As you can see, that the ventricle is very vertical, which is quite unusual. Over a stiff wire, then we dilated the septum. Since we anticipated difficulty in delivery, we used a 26 dry seal in this case, and we kept another wire for support. And in case we need to, we can dilate the valve additionally with a balloon. Though we didn't have an issue crossing the valve, actually, with the delivery system, we had, because of the vertical location of the LV or axis, we usually, and sorry here we didn't have the full inflation to show, we usually get coaxiality at the mitral valve annulus using a push-push technique of the wire and the delivery system. Didn't work here because whenever we push the wire, it's not translating into, making the valve stand up into the annulus of the mitral valve. So you can see a lot of tension, actually. When we inflated, we felt that the valve was diving a little bit into the ventricle, so we had to really, Dr. Antar is here, he was inflating. We had to really pull the sheath very hard. You can see we're moving the annulus backward here. But finally, we achieved a very good alignment with the 90-10, and then we post-dilated as we planned with an Atlas balloon, 26. This is the final result. We got a mean gradient of 3, down from 18, and the patient did very well. So just to finish with some data, we have a lot of data actually from the Guerrero Myra in the mitral trial. Those are high-risk patients. We know that valve-in-valve patients, they do very well compared to valve-in-ring and valve-in-MAC with the 80% survival at 5 years. And also from the TVT registry, including a large number of patients, about 6,000, we know that if you do those cases and elective, and if you do it for lower risk patients, they tend to have better outcomes shortly and long term. So the take-home points, transcatheter mitral valve-in-valve using Edwards SAPIEN, prosthesis viable alternative to surgery after heart team assessment, as in our case. Imaging pre-planning is essential to execute the procedure. You need to know the actual valve size to ensure that the operative note is correct with the correct valve size. And the risk of LVOT obstruction is usually low when compared to valve-in-ring and valve-in-MAC, and those are actually off-label. But the valve-in-valve is not off-label. Thank you.
Thank you, Mohammed. Fantastic case, great result. We saw that annulus pulling down. That was a little crazy. Let me bring it back. Let's start maybe with the indication. I'm gonna give you my perspective. I'm actually curious what our panelists think. But if you're gonna do a redo with a biologic valve, unless there's high-risk anatomy, shouldn't everyone get transcatheter? What do you lose by doing that? Assuming they're not getting mechanical, like this patient who refused mechanical. Shouldn't we be doing this on all of the patients?
So I think this is a very good question. I think one of the good things about a transcatheter mitral valve-in-valve procedure is it's a very safe procedure to do. So the risk of stroke is very low. The risk of pacemaker is extremely low. I don't know if there is a risk of pacemaker, probably very, very low. My main issue of doing this procedure on young patients is the fact that we don't really have long-term data about the efficacy of those valves on the long run. I know there is a recent paper by my friend and colleague Miriam Alkudad at CJC that showed really good outcomes at 10 years post transcatheter mitral valve-in-valve replacement. But I think patients considering doing that on such a young patient is not unreasonable.
So, very good question. So, my take about this: if my percutaneous procedure not going to complicate the surgery in the future, like for example, if you do an aortic valve and then with a long frame, and then you will end up with a Pental rather than just slam dunk aortic valve replacement. So if my percutaneous is not going to interact to the future surgical, I would go with the percutaneous as a first proposal.
So I think this patient had a biological valve for some reason at young age. Maybe she wants to get pregnant. She doesn't want mechanical valve for some reason. And I think now you can continue that option, and if it is feasible, and you will not end by patient prosthesis mismatch and gradient. If you can do that safely, I think it is very reasonable, especially she might have a procedure for her aortic valve, which is strategically is really wise. What do you think, Willie?
I agree. If there's no concomitant indication for surgery and patient not going for metallic, I would go for transcatheter. You want to save that sternum for later on. So I agree with you.
The problem is this valve is non-fracturable. Sometimes you intentionally fracture it, so you plan this patient even for the next time.
Right.
Maybe you can put another tissue valve. So because now you know that the LVOT obstruction risk is low, and now you just secured it with a SAPIEN. So if you put another one inside it, it just sealed.
Yeah,
But at some point we'll run out. She's 20-something, so at some point she's going to need surgery.
She will need surgery at one point. But if she gets surgery now, she may need another procedure in the future.
Dr. Khalid.
Actually, I will opt for surgery. Biological valves in the mitral position, they degenerate faster than biological valves in the aortic position because of the pressure difference between the LV and the LA. So if there is a possibility, long-term management for such patients young, I will opt for surgery. We don't know the long-term for mitral valve-in-valve because the leaflets are crimped. We don't know about the collagen, whether to be stabilized or not. You expand it with a balloon, you might sometimes post-dilate. There must be some sort of disruption of the leaflets. So long-term is very concerning. So I will opt for surgery, personally.
For biologic or mechanical?
Biological.
Redo biologic.
Redo biological, yes.
We have comments
thank
from
you
the
so much.
surgeon.
This is an amazing discussion, but I have to say something about. I think we should treat mitral valve as we treat aortic valve, as lifetime management for the patient. Usually, if you look at the data from surgical valves, the data on mitral valve and certain valves, 20 years freedom from redegenerations of up to 70%. So if this patient comes to us, then we discuss with the patients. I think you should also think about how many times are you going to do this procedure, valve and valve, valve and valve, valve and valve. So if she's 27 years old, she comes now, I would give her another redo biological valve because she is low risk, 27 years old. And also, give her a procedure at 27, she will require another procedure at 40 something, like so.
If you're lucky.
Yeah, exactly. So at that point, I think we should think about valve and valve and another valve and valve. But I think this discussion should be always patient-centric and consider, because the data on mitral valve and valve, it's, as you see, it's 5 years data, right?
They are up to 10-year data, yeah. But we don't have long-term data.
Yeah, so I think I would still I think it's a good procedure for a high-risk patient, but low-risk patient, they all should be considered for a redo operation because the data on even biological valve redo, it still outstands the data from valve and valve.
But in this case, if you would go for surgery, you probably want to replace the aortic valve too, with moderate AR, or what's your strategy?
Of course, if this patient ended up, because we would be concerned about protection, but all intraoperative decisions. What did you want to say something to that?
No, I was going to say the counter-argument to that is that she's in a childbearing age. You want to push her until she's out of that age, then she can go for metallic. Maybe that's the rationale behind not going for metallic. If you put her on a transcatheter tissue, 10, 20 years, even if it's a third procedure, then she might opt out for a metallic valve. I'm talking about if there's no other concomitant indication for surgery.
It's always, it's always a
No, it's a good discussion, yeah, but...
As we said yesterday, it's always nice to have a surgeon in the room. There's one more.
Dr. Kılıç from Turkey. Mohammed, congratulations, very fantastic case. I just want to make some little comments about technical issues. Very good case. You did body wire technique and etc. One important problem we had to know in this patient is the CT findings not only were restricted to the neo-LVT. Secured neo-LVT is very, very important, another term, and we must measure also secured neo-LVT to do Lampoon or Batman procedures. And also for the atrial septum, you know that these septums can be very thick if they do atrial replacement, transatrial replacement. So it is better to use the Atlas balloon for the atrial septostomy and sometimes to use the balloon-assisted tracking technique. But this case, very fantastic, and I really congratulate because when you put a bioprosthetic surgical valve, it is same with the bioprosthetic transcatheter valve duration. It is the Achilles heels of all bioprosthetic valves. So the decision is completely true, and congratulations.
Thank you.
Sometimes what we do, we don't use the A sheath, we use a dry seal, 24, 26, so we can prepare the valve inside the sheath instead of going deep and then you just put the sheath back.
Yeah. In fact, we used a dry seal in this case, actually. Yeah, we've fully crimped the valve on the balloon and we advanced it over inside a 26 dry seal in this case, and that also allows to use the body wire as well with the valve. 24, 26 would be enough.
So do you always
Use
rapid pace during the valve deployment?
No, not usually, not always. In this case, I don't think we even did rapid pacing. The issue with this case, positioning, in fact, the dry seal could have hurt us in this case because it looks like the dry seal has a valve that you inflate, and it was really hard to pull the sheath, and you can see how much tension I was pulling on the delivery system. Just for future cases, if you use dry seal, yes, you don't want the sheath to leak, but don't use too much, volume on the valve.
But definitely this is a two-operator procedure.
Exactly.
Close coordination is very important during inflation, positioning, very slow, and it has to have lots of coordination
100%.
between both operators.
And the most important thing that you highlighted very clearly and obviously that the puncture site is the most inferior and most posterior. You can see the Achilles catheter when you align the valve into align it in the RAO. You found that the Achilles is just at the lower edge of the valve itself. Looking at this left atrium, if you puncture superior, you're doomed. You cannot do anything.
I just want to comment about the dry seal. It's a must, as you said, because in case it couldn't cross, you need to get out and balloon it. So without the dry seal, it's going to be difficult if you have a lot of sheath.
Shorter one.
I'm sorry?
You use the shorter one, you don't take the longer one.
Yes, the short one. And the other point is that I don't do rapid pacing. The reason is that, as Dr. Khalid mentioned, so you can dance with your operator, you have your time. Overdrive pacing, you're going to take a very longer duration.
So just as a devil's advocate, I don't use dry seal, and I always pace.
Okay, so interesting. You can see the variation.
But it is very, very slow. Very long, slow, and you have to take your time to adjust. But I haven't actually tried it without rapid pacing. So, but it is a tricky two-person deployment. And I did so and back to your point about the dry seal because it may not cross. So I used to use 12 for the 26 and 14 balloon for the 29s, and then I got caught up once. Almost into the situation that you mentioned, why you use the dry seal. And
it happened to me too, that's why.
I eventually got it, but it was it took a lot of manipulation. So then I upped to 14 and 16, and then you have bigger residual ASDs, but at least then you take it out of your mind. This one was a tough hole. So did you feel? So you said 14 or 16 for this balloon?
For balloon, I don't remember 12 or 14. Just positioning the transeptal puncture was tough, but the septum itself wasn't tough.
Wasn't particularly thick or anything. So I think we need to move on. I want to introduce.
So next case is by Dr. Wade Al-Harbi, THV surgical valve.
Great job.
Assalamu alaikum. Assalamu alaikum. So I'm going to talk about TAV-in and a Stentless surgical aortic valve. This is a gentleman who's 76, frail, non-hypertensive, AFib, stage 3 CKD. He had a cabbage outside of the kingdom, a Lima to LED, and surgical aortic valve replacement with root freestyle 25 in 2013. And he had a pacemaker in 2024. Now he's presenting, as we know from the freestyle valves, with degenerative severe aortic regurgitation, was symptomatic. He had recurrent heart failure admissions, and that is really not up to quality of life. He was deemed at an outside hospital for palliative treatment because of the high risk of doing a TAVI or the redo surgical. So I'm gonna just show you the AI part. And you can see that classically they always have like a cusp perforation of the valve that cause a problem. The ejection fraction is moderately reduced. And it's a left dominant system. You can see there's moderate disease at the mid-segment of the left circumflex. I want you to keep a note on the ostial of the left main. How does it look? You can call it moderate to severe at that mid-segment of the circ. And have a patent Lima to LED. So you have a left dominant system, a Lima to LED, and freestyle valve. And I would like to get the comment of Dr. Mohammed from cardiac surgery, the different techniques of the freestyle, why we see variation on where is exactly the sewing ring for this type of valve.
The freestyle, it's a penile procedure. So you replace the whole root because my guess this patient has maybe root aneurysm with aortic stenosis. So as you can see here, the right and left coronary orientation in the pigs, the angle are a little bit more acute than human. So when you do that surgically, you orient the left cusp to the left coronary system, and you ended up sewing the left coronary to that bottom. That's why you see it how it's a little bit sharp angulation. And then the right coronary, most of the time, you'll not be able to put it into the right, in that spot. So you end up ligating it, and then you implant it a little bit into the little bit higher into the graft itself. So the beauty of this, in my opinion, freestyle should be used in patient who comes with infective endocarditis, because this it has a very good resistance against infection. But the problem with this, two things. It's if degenerate as severe aortic regurgitation, and usually the leaflet does not calcify, it gets fibrotic. And then you have a lot of calcification into the wall of because the way it's being preserved with glutaraldehyde, so it gets very severe calcification. So when you go back for redo, it becomes very difficult and challenging. There is no sewing ring, so as you can see here, they put the felt into subannular region, and this is when you put the suture. So practically it's like a normal viable root. That's why you should treat it as a native annulus rather than as stented aortic valve.
Dr. Muhammad, just one question while you're there. Do you consider the length of the leaflet and you intentionally implant the left main higher than the length of the existing, prosthetic valve leaflet, or you just go as high as you can, or you don't?
I mean,
really?
Usually if you do Mitral.
Since now we're in the era of transcatheter valves.
Be thoughtful for us.
Absolutely. In my operative note, when I do aortic valve or I do Mitral, I put in my note what's the distance between the annulus and the coronary, because for the interventionist, when he comes back, they need to do a CT, but they need to do, because in some cases, the coronary, it becomes very close to the valve, and I can say that it's like less than 0.5 centimeter, which is 5 millimeter. And I know this patient, if he comes back, he will have extreme high risk for coronary occlusion. But in this valve, usually the left coronary, it's very high, even if the valve, it will not close and when you do a regular Mitral with mechanical valve or with a bioprosthetic valve, usually the coronary, even when the valve opens, these valves are a little bit restricted, so it will not occlude, even if you implant the coronary lobe. But the concerns comes when you put a TAV-in, because when you put TAV-in, you will stretch the leaflet, and this might goes against the ostium of the left main.
Thank you, Dr. Mohammed. So a CT, if you're going to look, really difficult to know where is the annular plane. And if you try to measure the VTC, you can see it's 3.7 to the left main for the left coronary system, with a simulation of a 26 valve. The right, we don't care, it's a non-dominant small, and also we never looked at it. And here you can look at the sinuses, and the images are not optimal. There's some artifact. There's severe calcification. I'm going to show it in the following, as Dr. Mohammed mentioned. But really, we have difficulty to identify where is really the annual plane, or looking at the nadirs with this. And this is a classic of the freestyle. Sometimes even they get smaller than the LVOT. There's extensive calcification of the arch nodus, but there's a lot of fibrosis within the aortic ascending aorta. The femorals are good in the right, and the left there is, you can see there in the left iliac, common iliac, there's it looks like a thrombosis. So we left it alone, we didn't go through it. So what are the challenges with the stentless valve? There's no fluoroscopic markers. There is a lot of variation in the surgical technique with the freestyle valve that make it difficult to know exactly where, what kind of, how you're going to implant your valve, what's the depth of it, and that's challenging. On top of it, most mechanism of failure is the aortic regurgitation, usually it's a cusp perforation from the freestyle valve, and that makes it really difficult in positioning. And the risk of coronary obstruction, usually the implant is pretty low for the left system. Those all come together, make it very challenging to implant. Risk of coronary obstruction is high, and the risk of embolization make it higher. And you can see here, there's no radiobake for the valve, but this is from the Valve-in-Valve app by Vedic. And you can see here, it's very challenging that it's not the usual. You go really deeper than usual, and almost you go to the LVOT area. And actually good for the coronary. And that's what we try to identify, where's the hinge point exactly. And that's where you're gonna utilize different angles. You try to find out where is the hinge point so you can implant based on that. And I recommend, there's a very good paper by Veniak about the stentless valve, how to identify where is exactly the hinge points. If you're not sure about it, there's different techniques, which I did not use of it except putting a guide wire in the left main. So after taking the femoral shot, I want to take a look here and have an understanding where exactly, try to imagine where you want to implant that valve for you. And you can see here, I have an idea about the hinge point, but I'm not sure. I took a different angle. And I decided to really implant deep as in the valve app. And you can see here, it was high, then pushed a little bit down. I was really worried about the left main, so left circumflex because of the left dominant system, so I put in the stent beforehand. You can see here, we made sure there's filling of the left system, and then try to understand the depth of it. You can see there is probably mild AI on that left side. But here, the implant is pretty good. You see, I'm not taking the wire. I got burned once. I really want to make sure there's no interaction or any occlusion of the left main. And that's it. And I recommend this paper tutorial. It's really good by Babat about what are the challenges you might face with those with stentless or sutureless valve. That's it.
Thank you. So we'll keep the discussion till after the next case, and then we'll open up a valve-in-valve TAV discussion. So pleasure to introduce Dr. Ali Hussein with another interesting TAVI in a failed surgical valve.
For the kind invitation, and happy to be here. Today I'll be presenting a TAVI for a failed self-expanding supraannular valve. Those are my disclosures. So our case is an 82-year-old gentleman with a prior surgical aortic valve replacement using a 23-millimeter Percival valve back in 2019. Now presenting with worsening shortness of breath on exertion in keeping with NYH class 2 symptoms. The mechanism of failure is mainly bioprosthetic valve stenosis, so severely stenotic bioprosthesis. But there is also intravalvular and paravalvular regurgitation, so I'll be sharing the echo shortly. The patient has a low GFR, chronic kidney disease, prior stroke, and when calculating the STS risk score for a redo procedure surgically, it comes as an intermediate risk. So this is the echocardiogram. You can see the LV systolic function appears normal with an EF of 60%. There is severe stenosis of the surgical bioprosthesis with a mean gradient of 45, aortic valve area of 0.7, but there is also valvular as well as paravalvular regurgitation. So the Percival valve has a very unique design. Although this is implanted surgically, it's a 19-hole frame, sutureless, self-expandable valve with supraannular bovine pericardial leaflets. So you can think of this valve of a transcatheter, a tall frame, supraannular valve. It shares a lot of similar features to a TAV-in-SAV procedure. So this valve comes in 4 different sizes, small, medium, large, and X-large. Our patient had a medium Percival valve, 23 millimeter, which basically is implanted for an annular diameter of anywhere between 21 to 23 valve. So this is the angiogram prior to the valve-in-valve TAVI, and on the left side you see a very nice left main view isolating the left main ostium, and you can see that the left main originates above the commissural pulse of the surgical valve. So you would think this is a low risk for a left main obstruction. On the right side you see an RCA view, and also the RCA originates above the commissural pulse of the Percival valve. So really no major concerns for coronary obstruction. You always need to confirm this with CT, obviously. So the CT is very interesting. Now, there is mismatch between the native annular dimensions and the bioprosthetic valve dimensions. The Percival valve appears underexpanded to the native annulus. So it's a 23 millimeter Percival valve, medium size. The diameters basically range between 23 to 24 at different levels, but the native annulus measures a 26 millimeter valve. And this may account to why this valve degenerated early, only after 5 years post-surgery, but also there is significant paravalvular leak. There is really no Holt or Panis, and the leaflets appear to be calcified and degenerated on the CT scan. So if you look at the Valve-in-Valve app, they do recommend a 23 millimeter SAPIEN 3 valve inside this failed Percival valve. However, this is assuming full expansion. This valve is severely underexpanded. So this presents a dilemma in terms of sizing the second valve. Would you size based on the bioprosthetic failed valve, or would you size based on the native annulus? This is how it looks on fluoroscopy, and in terms of positioning, we were planning to go from the annulus all the way up to the commissural post, covering the stenotic leaflets. And as we said, this is very low risk for coronary obstruction. You can see on the angiography here, there is significant valvular as well as paravalvular regurgitation, and on the CT, both the left main and RCA arise above the commissural post of the valve. Access appears to be feasible bilaterally, so no major concerns with transfemoral access. There's some tortuosity, but very doable for TAVI. So in terms of summary, this is an 82-year-old gentleman with a failed underexpanded Percival valve. There is a severe stenosis as well as severe paravalvular regurgitation. The valve is underexpanded to the native annulus. And we know with those cases, crossing can be very challenging. So we were planning after heart team evaluation to proceed with a valve-in-valve TAVI using the right femoral artery for main axis, left femoral artery for secondary axis. We were planning to pre-dilate, and really depending on how it looks, potentially post-dilate as well. The plan was to go with a 26 millimeter SAPIEN 3 Ultra RESILIA based on the native annular sizing, not the bioprosthetic valve. So we sized based on the native annulus. And as we said, we're going to go from the annulus up to the commissural post. Now, this valve is very difficult to cross. Tried different catheters, different wires. Here you see a hydrophilic Terumo wire. And despite spending a long time to cross this valve, we could not really cross retrogradely. This is an example of how you should not proceed with crossing. This is the wires going inside the valve and then into the paravalvular space. So you really don't want to pass balloons or equipments when you see the wire behaving like this. So both videos here, this is a wire that is really not intravalvular. So we had two options here, either to stop, refer for surgery, but we did anticipate this may become a very difficult valve to cross. So what we did is we converted to GA transeptal puncture and tried to cross antegradely. So here you see a VersaCross system crossing the right atrium to the left atrium with an RF wire, and then cross the mitral valve as we normally do with a valve-in-valve, mitral valve-in-valve procedure. This is a VersaCross system with a steerable guide. You see the pigtail is positioned very nicely in the left ventricle. And then the next challenge would be to pass a wire through the pigtail up antegradely to the Percival valve, and we could not really do so. The wire was basically prolapsing back to the left atrium. So what we did is we switched the pigtail with a balloon wedge catheter, the same catheter we use for right heart cath. And that helps to go with the blood flow antegradely. And with that balloon wedge catheter, we're able to cross antegradely with a Terumo exchange wire. So this is the exchange wire long enough for crossing. And then the next step would be to make sure your wire is free inside the valve. So you may want to do a fluoro sweep, make sure the valve is not the wire is not really caught by any of the stent frame of the perceval valve, and then go antegradally down to the descending aorta. The next thing you need to do is through your main arterial axis where the expandable sheath, large sheath is, you can pass a snare the wire, pull it down into the right arterial axis, and after this, you basically form a closed loop from the right to the left system. Next is passing the pigtail through the arterial axis down to the left ventricle. And the worst thing you want to do here is lose your pigtail. Since the pigtail is very nicely positioned now in the left ventricle, pass a stiff wire, and then you basically do your procedure as you normally do retrogradely with a TAV-er. So next, we pre-dilated the valve with a 22 millimeter non-compliant balloon. You can see the valve is very tight. Delivered the SAPIEN 26 millimeter Ultra RESILIA valve. Very nice deployment and the rapid pacing. The valve expanded very well, nominal deployment. And the final root angiogram showed a well-expanded valve with really no paravalvular leak or intravalvular leak, nicely positioned. You may think it's on the lower side, but the perceval valve was also deployed very low, and the coronaries are very, very high in terms of native anatomy. So the echocardiogram post-procedure showed a well-seated valve. There's really no intravalvular or paravalvular regurgitation, and the peak gradient was only 12. So we thought that was a very good result. So to summarize, TAVI for a failed perceval bioprosthesis can be challenging. Be aware of the index bioprosthesis and their expansion, and in some cases, you may want to size to the native annulus, not to the failed bioprosthetic valve, especially in the absence of adverse root features. So also, this highlights the importance of reviewing the first CT scan prior to the first procedure to look for annular calcification, alveolar calcification. If the annulus is low risk, you may want to size to the native annulus. And we also showed that antegrade crossing is feasible if retrograde crossing fails. Thank you for listening.
Dr. Ali, the most probable cause here of valve failure is underexpanded valve. And now when you balloon, and would you look into different angles to make sure that you have, expanded that segment? So what you don't want to do is to put another valve which is underexpanded and will have the same mode of failure. So did you try to see it into different views? Would you do CT to make sure that it's fully expanded?
So I have
The other point, I think the perceval valve was implanted very deep.
That's right.
So would you go by the app, you go to the lower part, or you just implant it higher than what it's supposed to be?
So I'll answer the second question first. I think the implant depth is important, but really depends on the mechanism of failure of the first valve. If it's purely stenotic, you want to cover up to the commissural post because this is where the functional leaflets are. You don't want to go deeper and then have a leaflet overhang that are stenotic, calcified, and then cause a residual gradient. In regurgitant valves, you have the option to go lower. For this specific case, we felt you can go with a 26 valve is tall enough to cover up to the commissural post. There's really no need to go higher. And then I agree with you, the valve may have been slightly underexpanded. Sometimes we check on the cusp overlap view, and you tend to appreciate more THV under expansion in the cusp overlap than the three cusp view. But this was a very long procedure, so we were very happy with the result.
Did you ever see the infolding on fluoroscopy, or was it only the CT? Were you able, before you deployed, did you ever see it?
The infolding?
An underexpanded infolding at the inflow? Or never fluoroscopically,
right.
Never visualized fluoroscopically?
I think the hint was the dimensions of the valve in comparison to the native.
Yeah, of course. No, you did a great job.
You still could do CTs next day to see the valve. And if it is underexpanded, I don't know somebody experienced like Dr. Mohammed Abdul Wahab can tell us, if it's underexpanded, you can bring him back and balloon it. What do you think, Dr. Mohammed? We all agree on that.
Yeah.
I don't know about the surgeon here.
It's not a classic surgical valve, it's like, it's actually like that.
Yes.
Because it's like a rapid deployment valve, and it's self-expanding valve, and this is why it's prone to under-expansion, infolding, and so on. So you don't have this with the regular surgical valves. So I've never seen an infolded perceval before, but I could imagine it could happen. And your approach, I find it very interesting. Initially, I thought, oh, he's taking a 26 valve, could be a little bit too big, and maybe it will lead to under-expansion. But at least visually, fluoroscopically, it seems to have expanded well and probably corrected the infolding that the perceval had. But I agree that a CT would have been extremely helpful and insightful in this particular case to understand what happened, because obviously also somehow you got rid of the paravalvular leak, so maybe the paravalvular leak was also like part of the infolding story.
But my point, Dr. Mohammed, you can always bring the patient back after a couple of days. We can just expand it well.
Yeah, but I don't think we have clear evidence yet that we should just expand valves to make them look better. We are, of course, it's evolving. We're now understanding that probably expanded valves could be better than under-expanded. But to bring a patient back to improve expansion if the patient has good hemodynamics and no leaks, I don't think we're there yet.
Dr. Mohammed.
Thank you so much for these great cases. And in limited experiences that we have with this valve, we're using the angled pigtails instead of left arm plus or right joint cans, because the problem is that in these valves is wide stress and almost always the wire pass from this. But with angled pigtails, this happen rarely. And the other thing, in this valve is implanted very low, and deploying the other valves in that region, there is some reports of late migration that the next valves in 12V. And maybe trying to deploy it a little bit higher if coronary has this capacity, maybe it's better than low implantation.
Thank you for your comments.
Ali, congratulations for this case. I want to make a comment about the Stentless aortic valves. We have got a lot of problems in our country, that a lot of paravalvular leakage, early degeneration, and it should be kept in mind that I know that there's a surgeon, maybe he can make some comments here. Surgeons never look at the CTs before valve replacement. So these results, one, patient prosthesis mismatch, and the other one, when they use Stentless valve. No, we will publish a warning. When they put the Stentless valve, we see always paravalvular leak, especially with the perceval. Why? Because of the low radial force. In the audience, there was a question when you present the presentation, why, for example, post-dilation didn't done? Because when you post-dilate this valve, it's recoil again. The problem is they select a little valve, and according to, for example, the measurements, we put a higher balloon expandable valve in this case. So it should be always kept in mind in the new challenging area. Surgeons must look at the CTs before the operation. Thank you.
You're making our surgeons unhappy now.
Dr. Makhani.
Nice case, Dr. Ali. Did you try rapid pacing? Because usually stenotic bio, it's a pinhole, difficult to cross. But you know, regurgitant shouldn't be, maybe difficult, yes, but should have tried maybe rapid pacing. Did you try it?
Try rapid pacing?
Rapid pacing? No, not rapid, I mean 200, 140, just to try to cross the valve.
I personally haven't tried that approach, but I find it a very interesting idea. This valve has a mixed pathology, severe stenosis as well as regurgitation. I'm not sure if that's going to help, but it would be interesting to try.
Okay, so there is it's very interesting discussion.
You're taking all the stress of all surgeons on your shoulders.
I'm not the best one to defend Perceval because I personally don't use it, because I believe, as a surgeon, I love to control everything, and this valve sometimes you can't really control because it's self-expanded. Look at it, it looks good intraoperative, but then you ended up, as you hear, that there is some paravalvular leak. But I think for you to understand, you have to understand two things. First of all, how do we size it? And second of all, how do we implant it? So for you to come back, I don't think this valve is under-expanded. I don't think so. This valve is actually missized because the annulus is big, the valve is small. And this valve degenerates not because it's under-expanded, because there's a lot of paravalvular leak which make the valve degenerate faster. That's why you'll be able to actually put a very big size valve. So first of all, what we do, we actually remove all the leaflet, as you do, and you keep some calcium because you want the valve to anchor. Then at the nadir, where actually the mid portion of each leaflet, we put a guiding suture. Then we brought the valve down, and then we start deploying. So practically, you deploy the valve at the level of the annulus, but there is subannular curtain that goes down. That's why the valve looks a little bit deeper, because it goes a little bit into the LVOT. So when you try to put TAV-in, you have to also look into the leaflet height, because his leaflet is very little bit longer. So you want to also, but usually, as you can see, the cage of the valve, it's very wide. So the risk of coronary obstruction in this valve are low. And also the valve implant, it's as you said, it's lower. So risk of coronary occlusion is not very high in this particular case. But always the concern is the sizing, because they give us the sizer, we put it inside, and we start shoving it. Oh, looks good. It has to be snug. But then they change it from Perceval to Perceval Plus. They change the design of the valve. But I believe if this patient, it was done in 2019, he's 82. So I believe when he was done, he was like 76. I will not do Perceval valve for AVR. I will just send him for TAV-in, because TAV-in showed a better outcome than if you're going to do sternotomy, stop the heart and do Perceval valve. I will rather do TAV-in for him. I will not send him for Perceval. I think Perceval should be done for a patient. Either they're going have very high risk for example, left main and AVR, maybe. But I think in a very good skillful surgeon, doing sutureless or suture valve should not take, I think it will take almost similar time. So I personally don't use Perceval valve, but I'm not here to defend it or not defend it, but there's some surgeon who love it. They said, I'll do Perceval. But I think the concern is the sizing. Because if it's under-expand, it will degenerate, and if it's downsized, if it's not a good size, it will degenerate. Thank you.
One question about the technicality. So you probably measured the LVOT, and in this case, the LVOT size was similar to the annulus?
Yes, so it accommodates a 26 valve. So I just want to make a comment here. It's not routine to size based on the native annulus, not the bioprosthetic valve. In this case, we felt it's appropriate because we felt if we do another 23 inside that Perceval valve, you can still have a residual leak, because the first bioprosthetic valve is small to the annulus. So do you do CTs routinely prior to your SAVers now?
I think we should close.
Very short comment. Unfortunately, there is only one paper about long-term results of Perceval, and only one paper from the center in the literature.
No, I think we all agree nobody likes Perceval. I think it's a group audience. Just one last question maybe for Waleed, because you showed us similar. I think we showed two different reasons we used balloon expandable valves for valve-in-valve. Yours was for coronary access. In this case was to get better expansion. I'm going to ask just a quick general question. Has the gradients with the RESILIA affected your decision-making? Because a lot of people prefer self-expanding valves in the valve-in-valve because better hemodynamics. Does the RESILIA having better gradients, does that change things? Does that change the measurement, or how do you favor it in your choice?
Well, usually if it came out it's 20, for example, I would not go for a ballooning span valve. But I haven't seen an issue with 26 and above with gradients post-implant. 23 make me think about the self-expanding supraannular platform. That's my usually my
Based on size.
based on size usually, and if there's any other risk that would entail.
We're out of time.
Yeah, I think we'll come to the end of the session here. So we have seen that valve-in-valve procedures are growing alternative to redo surgery. So, but the valve-in-valve carries higher risk of coronary occlusion, LVOT obstruction in the case of mitral valves, difficult coronary access in the valve-in-valve and the aortic valve, and patient prosthesis mismatch. Pre-procedural evaluation is very, very important to reduce the risk of complications. We have seen the SAPIEN 3 was the first valve to be FDA approved for the aortic valve-in-valve, and maybe it's the only valve approved for mitral valve-in-valve with excellent hemodynamics. So now the question that Mahmoud was asking is, having a better hemodynamics will make it the ideal valve for valve-in-valve. And it has a excellent lower risk of coronary access in case of you do it in the aortic position. Thank you very much. So we'll break for the lunch, and then after that we have challenging cases session after the lunch. It will be very interesting.